Good afternoon and welcome. Thank you for joining us for our training, The Importance of Diversity Informed Practices in Trauma Informed Care, Part 1, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder trainings to nursing facilities nationally at no cost to the nursing facility. And now, I am happy to introduce our presenter for today, Dr. Laverne Collins. Dr. Collins is a national certified counselor who holds credentials as a licensed clinical mental health counselor in North Carolina and a licensed professional counselor in Georgia. She is a certified coach, clinical supervisor in grief, trauma, mental, telehealth counseling, and addiction counseling. Dr. Collins has over 25 years of experience in helping people manage life's unexpected crisis, grief and loss issues, relationship issues, and mental health. She is the owner of New Seasons Counseling, Training and Consulting, and Collins Life Coaching. I'll now turn it over to Dr. Collins to begin the presentation.
Dr. Collins, you may be on mute. There you
There we
go.
go. Yes, thank you. Thank you, Nikki, and thank you, Derek. Appreciate the kind introduction, and it's my pleasure to join you today to talk about this really important topic of the importance of diversity-informed practices in trauma-informed care. Our objectives over a two-part series will be to first explain the significance of bringing diversity-informed practices into trauma-informed care for nursing facilities. That is what we'll cover today. In part two, coming up in February, we'll consider structural and systemic inequities as re-traumatizing experiences and discuss how different cultural groups might perceive and even respond to trauma differently. But today, again, we're about explaining the significance of bringing diversity-informed practice into trauma-informed care. I don't believe you can effectively have a trauma-informed care without diversity-informed practice. You really can't have diversity-informed practice without trauma-informed care in our facilities. So let's start with that, the significance. And we're going to begin with some basic definitions. These are probably not new to you because you've been in other trauma-informed care programs through this series or others. But let me just come with the definition that I'm using today. Trauma is the result, that's important, it's an important word. Trauma is the result of an event, what we would call a traumatic event. We often talk about trauma as being the event, but trauma is the result of either an event, a series of events, or some circumstances that are experienced by an individual as physically or emotionally harmful or life-threatening, and that result has lasting adverse effects on the individual's functioning and their mental, physical, social, emotional, or spiritual well-being. And this is the SAMHSA definition that I'm using. It's important to think about trauma as not the event, but the result of an event or series of events. Now, I'm going to ask you to remember tick and dip. They go together like chips and dip, right? Tick, obviously, trauma-informed care. Dip is diversity-informed practice. So again, just by way of setting expectations for the meaning of terms and definitions, trauma-informed care is an organizational structure and a treatment framework. It's not a treatment methodology, it's a framework, it's a mindset, it's a culture that involves understanding, recognizing and responding to the effects of all types of traumatic events. Trauma-informed care emphasizes physical, psychological, and emotional safety for both consumers and providers, and helps survivors rebuild a sense of control and empowerment. That is so important. Control and empowerment being given back to the person who has experienced the traumatic event. Now, diversity informed practice goes right alongside that. And diversity informed practice, I call it a dynamic system of beliefs and values that shapes your interactions. It shapes the interactions between individuals, organizations, and whole systems of care. Diversity informed practice recognizes that there's a history, and that history is salient. That history related to a person's race, ethnicity, class, gender, sexuality, age, their ability status, xenophobia, homophobia, forgive me, and all the other systems of oppression that people experience. And diversity informed practice then strives for the highest possible standard of inclusivity in all the spheres of our practice, teaching and training, research and writing, policy and advocacy, and direct service. So, trauma informed care recognizes that people who have been through traumatic events and experience trauma within need a sense of control and empowerment. Equally so, people who have been marginalized, racialized, otherized also need a sense of control and empowerment. We can think about trauma, but if we don't think about the person's history, we may be overlooking causes of trauma and traumatic events. So we're putting these two together, tick and dip. Here's how I learned about the importance of diversity-informed care and, I should say diversity-informed practice intersecting with trauma-informed care. You can see this is the skyline. I don't know if anybody recognizes this city, but this is my home city of Pittsburgh, Pennsylvania. And you've heard of the Three Rivers. There used to be Three River Stadium, but the Allegheny River, which is to the left, and the Monongahela River, which is to the right, both flow into the Ohio River, which is what begins at the base of that fountain. I believe that effective care, just to use this as a visual, effective care is the intersecting of diversity-informed practice and trauma-informed care. The Ohio River is much stronger than either the Monongahela or the Allegheny, but together they form the mighty Ohio, which feeds into the Mississippi. Now, let me tell you what happened in Pittsburgh, because that's where I began my work in mental health and substance abuse. My very first position as an intern, I did my internship and my practicum in a residential substance abuse program in the inner city. We had a lot of co-occurring disorders. We served 20 to 24 men and women. Many of them were in a jail diversion program, probably about 75%. The residents were 90% Black and Hispanic, probably 10% white, typically not many other racialized or minoritized group members. And the program was long-term residential. Back in the day when a program could last 9 to 12 months, you could actually get funding for it, right? So let me tell you about this program. Obviously, you know, when people are struggling with substance abuse, there's a lot of shame. There's typically trauma. But this program, with all the right, all the right funding from county and state and other sources, private funding, had a very low program completion rate. Why was that? Because it did not have diversity-informed practice. There was cultural sensitivity that was present socially, but that didn't transfer into the clinical work. There was no trauma-informed care. There was no evidence-based protocol. It was like anecdotal only, and there was a high incidence of re-traumatization. Now, when I went to that program, it was the early 90s, probably around 1994, mid 90s, 94 and 95. And I got to tell you, this image here of a gentleman standing in the corner with a dunce cap, this program had just, when I got there, had just stopped using techniques like this, where if you broke a house rule, you would stand in the corner or sit in the corner with the dunce cap. I'm told that um, they had actually, at points, had people in diapers with baby bottles to teach them not to be immature. Was that re-traumatizing or what? Yes, absolutely. Was that trauma-informed care? No. Was that diversity-informed practice? No. So you can see the high rates of re-traumatization. There was resistance to moving toward evidence-based protocol. So I stayed for my practicum and my internship, and then I left because I recognized that what was going on there was totally contraindicated. And the program, until they got beyond those anecdotal interventions, when I say anecdotal, I mean the staff would say, well, it worked for me, it's got to work for them too. They were writing the prescription out of their own history. And that just was not working. So what we now know is that diversity-informed practice and trauma-informed care are so intertwined that facilities, nursing facilities, residential substance use facilities cannot effectively have one without the other. So in these two sessions, January and February, we're going to consider the importance of cultural responsiveness, both individually and systemically, to culturally diverse and marginalized groups, for people who have experienced traumatic events and experienced trauma in their day-to-day realities. US trauma rates are high, and they're even higher for marginalized groups. Consider this: 70% of adults in the United States, or 223.4 million people, have experienced some type of traumatic experience at least once in their life. And there's a direct correlation between trauma effects and physical conditions, because why? Trauma is in the body. Physical conditions such as diabetes and COPD, heart disease, cancer, high blood pressure. And the rate of traumatic experience is staggeringly high for members of demographically marginalized groups. Let me show you some of these statistics. For any trauma, let's consider these examples. For any trauma, the lifetime prevalence of exposure to any trauma for racial and ethnic minorities, 76.37% of African Americans, 66.38% of Asian, Hawaiian, Pacific Islanders, 68.17% of people who identify as Hispanic. Let's look at PTSD, lifetime prevalence, African American, 8.7, Latino 7, Asian 4.0. These are the highest reported rates of prevalence amongst all racial and ethnic groups. Let's look further. Early death loss. Black families have over 3 times higher odds of experiencing the death of 2 or more family members by the age of 30. Black families are about 90% more likely than whites to have experienced 4 or more deaths by age 60. White families are 39% more likely than Blacks to have never experienced a family loss by age 60. That's staggering. Look at Black maternal mortality and infant mortality rates. Black women have the highest maternal mortality rate in the United States, with 699 per 100,000 births in 2021. That's almost 3 times the rate for white women, according to the CDC. Non-Hispanic Blacks and African Americans have 2.4 times the infant mortality rate as non-Hispanic whites. Non-Hispanic Black and African American infants are almost 4 times as likely to die from complications related to low birth weight when compared to non-Hispanic white infants. And that's according to the Health and Human Services Department. Now, all of these are traumatic events that generate trauma in the body. Let's think about hate crimes. Racial and ethnic hate crimes are highest as follows: African Americans, 62.7%, Latina, 47.4%, Asian, 6.2%, Native American, Alaska Natives, 4.6, followed by multiracial individuals, and then Latinx when it comes to experiencing hate crimes. That's a traumatic event. Violent crimes. You can see that the average annual rate of violent victimization, including rape, sexual assault, robbery, aggravated assault, simple assault, committed by strangers, is highest among Native Americans, followed by multiracial individuals, followed by African Americans, followed by Latinx. So in all these categories, it's your racialized groups that are experiencing these extremely high rates, excuse me, of victimization. Even war-related trauma, lifetime prevalence of exposure trauma resulting from war, political violence, or war-related events, first for women here parenthetically, and then men. For women, 10.6, for men, 19.14. For Latin women, 3.94, for Latin men, 10.3. For African American women, 2.09, for African American men, 13.6. Again, these are the 3 highest prevalence rates, communities for these kinds of trauma. So you can see that the trauma experience, the traumatic experiences for people of minoritized groups is just, it's at the top in all those different trauma categories. Now, there are a lot of ways to visually depict trauma, and there are a lot of trauma trees that you see out there, but this is mine, and here's how I represent trauma with this image of a tree. You see the tree, you see the branches, the trunk, and then the roots. I suggest to you that the tree, the leaves and the fruit can be represented or represent behaviors that we see. I suggest to you that those small branches are the diagnosis, that the big trunk would be bodily system stress, our core functions, and that the roots of the bodily system stress that we recognize with a diagnosis, that we recognize because of behavior, the real root are the traumatic experiences. So let me show you. What do you see in terms of behaviors that are hard to deal with in nursing facilities and elsewhere? Well, you see abusive language, non-compliance, fear, resistance, self-medicating behaviors, mistrust, anger. Sound familiar? Probably so. Those are the behaviors that we consider to be problematic and difficult to manage. The diagnoses associated with those, think things like depression and anxiety, substance use disorders. Physically, diagnoses like hypertension, diagnoses like arthritis, and we could name many other diagnoses that manifest with those behaviors, that fruit that you see on that tree. What we don't often think about, however, is that what's underneath the diagnosis is really bodily system stress, stress of our core functions, oxidative stress, for instance, which contributes to all manner of autoimmune disorders and cancers and mental health disorders. And there's inflammation, there are your endocrine system problems and hormones that get out of whack, your thyroid thyroid gets out of whack, and the psychological stresses, all of these are stresses on our body's core functions that produce diagnoses, that cause us to see behaviors. Again, as I said before, what we don't often think about is the fact that what causes the stress with the core functions of our bodies are the traumatic experiences. Those bodily system stresses, those core functions being disrupted are a result, or that's the physical manifestation of trauma in the body. Now, we understand trauma as being car accidents, war. We understand trauma as rape and other kinds of assault. But when we think about diversity-informed practice, we must look at the trauma that is inflicted or is experienced by people who are marginalized because of their race or other identifiers, other identity factors. And what are some of those traumatic experiences that can lead to those bodily system stressors, the stress in their core functions? Well, stereotyped judgments. When a person from a marginalized or racialized community walks into a job interview or into a store and can tell that the people they are interacting with are working from stereotyped judgments and prejudices that they have learned in life. And now those stereotyped judgments are affecting how they're being treated. Let's think about disenfranchised grief. What does that mean in this context? Disenfranchised grief is the grief that is not socially recognized, the grief that you don't get support for when you experience it. Society doesn't honor it and give you 3 days off when you are carrying the grief of, say, the burden of being presumed guilty rather than being presumed innocent. The way that people are treated when they're racialized and marginalized and otherized leaves them with a grief because of closed doors and missed opportunities, opportunities that were denied to them. The burden of again being presumed guilty before they're presumed innocent, the weight of being disrespected or feeling invalidated because of their race. All those things cause grief, but there's no one to say, you know what, I know that's grief for you, and let me respond to you in the same way I would respond to someone grieving anything else. Homophobia, heterosexism, the heavy impact of COVID, for instance, on minoritized communities and racialized groups. Medical racism. Medical racism is real. You read about a few slides ago about the infant mortality rates and the maternal mortality rates. Some of that is because Black and brown women are not trusted, not believed when they say what's going on with their bodies during pregnancy or during delivery, and it results in a lot of unnecessary loss and death. Hate crimes, poverty, the early losses of life, as that one slide talked about, the prevalence of experiencing the deaths of family members before the age of 30 if you're in a racialized or marginalized or otherized group. Historical trauma, discrimination, I mentioned the presumption of guilt, and crimmigration. Crimmigration is the intersection of criminality and immigration, where immigrants are presumed to be criminals. All of those things create trauma and stress in their bodily systems and core functions, stress that you can't see. But what do you see? You see a diagnosis on paper and you see the behavior in front of you. This depiction here helps us understand that trauma-informed care must include diversity-informed practice. In other words, we have to be aware of all of these traumatic experiences that may have been in the lives of the people who are residents in your facilities, where you see this because they've experienced this. You might be able to think of other kinds of trauma that are based on the identity of a person's race or age, ethnicity, sexual orientation, or gender identity, maybe other kinds of trauma that is based on socioeconomics or ability status. I'd like to just open up the floor right now. You can open the mic or raise your hand if you'll help us out, Derek and Nikki, so we can hear from folks who might want to share other kinds of trauma they can think of that are based on a person's identity in a marginalized or otherized or racialized group.
Thank you, Dr. Collins. Just looking to see if we have anything placed in the chat.
Yeah, and I'll go back so you can see some of the things that I've listed there. The heavy COVID impact, discrimination, the medical racism, the early losses in life. And we know that when when you're a child and you lose a parent or a caregiver or a very close grandparent at an early point in life, the uh, the chances of experiencing depression and anxiety later in life are exponentially higher when you've had early childhood losses. Think about the impact of racial battle fatigue. And racial battle fatigue is that that wearing down because of continual microaggressions. People saying, "Oh, you're really pretty for a dark-skinned girl," or "Oh, wow, that's a good neighborhood. How long you been living there?" What's the implication there that dark-skinned girls aren't supposed to be pretty and that you don't really belong in that neighborhood? You don't fit? You hear that day in and day out. It's a weathering effect that wears you down. And the wearing down is known as racial battle fatigue. Someone said to me one time, "Oh, well, you know, things are changing on that side of town." And the side of town she was referencing was my side of town. And I thought, things are changing. Wonder what she means by that. No, I knew what she meant by that. It was becoming more and more integrated, more and more diverse. She saw that as a sort of things are changing, as if that was not a good thing, was a bad thing to have that kind of a change, a microaggression. So anybody else have other ideas, other suggestions, other contributions to the kinds of traumatic experiences that might be experienced by someone, not just by race, but age or sexual orientation, gender identity?
And on my end, Dr. Collins, that's exactly what I see: ageism and uh, heterosexism.
Mm-hmm.
Uh, and someone's definitely agreeing also with early losses as well and historical trauma.
Yes, yes. Historical trauma is that trauma that comes from, say, for Native Americans, having ancestors who were put into boarding schools, taken away from their families so they could be stripped of their culture and made to act more white, where their culture was denied. Historical trauma is the effect of slavery or the effect of immigration violence and other kinds of experiences that might not have uh, impacted the person didn't necessarily live through, but epigenetically and psychologically and culturally, they are still experiencing the after effects, the lingering effects of trauma genetically. And it's interesting. I'll add one other point to that before I move on, that studies with the I think I have a slide coming up on that, but studies on descendants of Holocaust survivors show that 3 and 4 generations later, they still have altered stress hormone profiles. So that tells you something. Okay, thanks for your contributions there.
We have someone sharing something before we move. You may would like that. For me,
Sure.
uh, it's here we have it. Thank you, Stephanie. For me, my family moved around a lot as my dad was constantly trying to find a better living for his family. With not having much money, I was teased a lot for not having the designer clothes. I was
Mm.
also taller than anyone until high school, so I was constantly called Bigfoot or Sasquatch. Thank you, Stephanie, for sharing.
Mm, thank you. Yeah, that's ooh, that is that bullying. And we didn't talk about bullying, but yeah, bullying is traumatic. And when it's based on race and identity specifically, it's hard stuff. It stays with you.
And blended families.
Yes, blended families can experience a lot of stress by trying to come together, particularly if some of the family is not as on board or struggling with the changes and the adaptations and all that that means. So yes, thank you for that. So here's our image. When you're looking at the tree, maybe you're searching among the branches for what only appears in the roots. Quote from Rumi. So there's another statement, another quote, that if you or you have to heal the root so the tree is stable. We're looking at the behaviors. We're writing in their charts that there's anger or there's resistance and they're non-compliant because we see mistrust or we see the abuse of substances, and we focus on the behavior. We look at, a diagnosis because we have to put one, but we often will put a very harsh diagnosis, a borderline personality disorder diagnosis or something like that. And we're focusing at what we see above the ground, not even thinking about the traumatic experiences that are producing the core function stress, the bodily system stress that's causing those diagnoses. Ah, so you have residents who are highly reactive. What's that about? A male resident throws his food tray at a staff person. May not have anything to do with that staff person or that tray. An older male lifts his crutch to threaten the staff person. Another resident picks up her walker and shakes it at a staff person. Those things happen. And in that moment, we're thinking that it's about that moment. But rarely is it really only about that moment. Studies show that many people accessing mental health care have a history of trauma and often experience re-traumatization in acute mental health inpatient settings. The treatment for trauma is just not explored routinely as a treatment option. Nursing facility staff may not draw connections between the trauma history that's beneath the surface and the residents presenting mental health problems. And as a result, we have staff persons who are um, re-traumatizing, missing signs of trauma in marginalized populations. So here's another question in terms of implications and application. What might contribute to a staff person missing signs of trauma in marginalized populations? Treating symptoms, time limitations. can raise your hand to request that your mic be opened.
Okay, we're seeing staffing, limited verbal
Mm-hmm.
communication,
Mm-hmm. Yeah, all of those things might contribute to a staff person missing the signs of trauma.
lack of training,
Lack of training. Yes. Language.
transference,
Mm-hmm. Mm-hmm. And I'll add to that, in addition to lack of staff education, I'll add to that that when trauma screening does not take place during assessment, the staff is less likely to find out about a person's trauma history. So the lack of screening is probably one of the bigger reasons why staff can miss that. Now, and competing priorities, I see that too in the chat. Thank you. Now, when we see trauma, we get trauma effects, we get unnerved. And I said before, we begin to judge people for being non-compliant. It's very easy to do. It's just frustrating. But trauma behavior is really the brain doing its job. Yeah, how about that? Yeah, the shock on this woman's face. Trauma behavior is the brain doing its job. Let me explain what I mean here. Very briefly, um, the central nervous system has a sympathetic nervous system and a parasympathetic nervous system, right? The sympathetic is like the gas pedal, the parasympathetic is like the brake pedal. The gas pedal is what gets pushed when we're being chased by a lion. Fight or flight, protection, survival. It's a stress response. The adrenal glands get activated. Yeah, and you're going to outrun that lion or fight that lion. You're going to do whatever you have to do to survive. But whenever the threat is over, the parasympathetic system is supposed to balance that, kick in again, and be like the brake so we can get back to normal functioning with rest and digestion and relaxation. And so the whole body is not mobilized for survival. It's like a switch though, because whenever you experience trauma in that moment, all these things happen. The heart rate accelerates, your blood vessels constrict, blood pressure goes up, muscle tension, physical sensations amplify. You have the inhibition of insulin production, so you can maximize fuel availability. Cold hands, feet, headaches, all that's what happens. All those things happen. You're supposed to be able to return to baseline where you get digestion again and your insulin activity gets regulated, where your immune system gets back into its flow, circulation to the non-vital parts of your body, because when you're fighting, in fight or flight, circulation is focused on what's needed for strength and reactivity. Endorphins can get released again when you return to baseline. It's going to bring down your heart rate, your blood pressure, your body temperature, all of that stuff. And the switch that this turns on, it turns on with rapid fire speed. So the activation of that reactivity is the correct physiological response. Now, it may not be logical or reasonable or rational all the time because it's dysregulating with intentionality. It's supposed to dysregulate or shut down the systems that are not essential in that moment for escape or victory. That should be temporary. But what happens with trauma histories, especially developmental trauma histories, is that they get in that the person gets in that sympathetic nervous system response that's designed for survival, and they stay in it. They're in it all the time. They stay in it longer than the brain is supposed to. So it's then suppressing non-essential systems that you need in order to function. And we become sympathetically dominant. the sympathetic nervous system becomes the dominant system. Why? Because we're reacting to an environment that's teaching our body to be in that state. And when we move into that hot system dominant state, excuse me, we actually become more in tune to the environment. So you have this hypervigilance. There's a greater level of attunement to the environment. And guess what? Everything looks and feels like a lion, because that part of the brain that is um, uh, like a radar. So I say, like a radar looking for threats and looking for danger is always active, because that person has been always in a threatening or threatened, excuse me, in a threatened state. The squirrel looks like a lion, and that system activates so very, very rapidly. What we need, what we need is a new response. We tend to tell people that their behavior is bad when their behavior is actually a normal, predictable response to the environment that has been threatening to them. And at that point, every environment seems threatening. The most problematic behaviors are the ones that are congruent, correct adaptations when your hot system is in a state of dominance. I think about my ancestors, for instance. I'm a descendant of enslaved persons. I think about what it must have been like on plantations, where every day you're at risk of being beaten or lynched, or to try to escape, having dogs chase you, and to be at risk of having your family torn apart by um, being sold. Your children could be sold, your spouse, your parents, anyone could be sold downriver. Um, that's like being chased like a lion, being chased by a lion, like every day. Every day has the possibility of unpredictable, maybe I should say predictable trauma. And when you're in sympathetic dominance, that system kicks in 7 to 8 times before the executive system can kick in even once and say, wait a minute, let's not respond like that. Um, Again, this is a physiological response in the body. The events are what is traumatic. And when we're in that hot system for a long period of time, that symptomatology gets labeled as pathological. The reality is that what gets diagnosed as behavior problems, both in kids and as psychiatric problems in adults, is really the manifestation of the system working the way it's supposed to. But the person was not supposed to have been in an environment where trauma was a regular, predictable experience. And again, I mentioned the radar system. The radar system, it comes from the anterior cingulate cortex, and it's an environmental filter for the things that are relevant to your safety. And that's what activates the body to respond. Again, the longer we have to stay in that sympathetic dominant state, the greater the degree of focus on threat, and the greater the degree of focus on danger. So when that resident raises a cane, or another resident raises their walker, or a person throws a tray, they may often be responding out of their trauma, because their focus has been on threat and danger, because that was their reality. So we have those traumatic events. We have ongoing environmental trauma. When there's a wound, the body responds to the wound, but we don't have to have a physical wound for the body to have a trauma response, obviously. Experiences like discrimination and marginalization, microaggressions, all those things that were in red underneath the surface, in the roots. And you have this cumulative harm effect in the environment where you get small doses many times a day, small doses of microaggression, small doses of marginalization, small doses of discrimination. That is just as significant as the major events that we would consider. And without the recognition of the influence of that, then we are not really bringing diversity-informed care into our trauma-informed care. Now, it's the unhealthy systems that keep sympathetic dominance alive. When people are in chaotic and aggressive or abusive environments where there's inconsistency, where there's unpredictability, where there's instability, where there's this constant threat of, am I safe? Am I safe? Am I safe? Sympathetic dominance is going to be prevalent. But when people are no longer in systems where they can't feel safe or where they don't feel like they have control, then the potential for the sympathetic dominant responses drastically diminishes. But when those systems stay active, we call them disorders because the brain is doing what it's supposed to do. It's supposed to keep us alive. The brain helps us to survive. And when you get the repeated activation of that radar, your threat perception is sharpened, it's more acute, you perceive threats more readily than someone who has different experiences. And they're right based on their experience of a regular threat. So I mentioned how quickly that system kicks in. You can access, your ACC can access your entire physiology in just 15 milliseconds. In other words, that system's going to activate 8 or 9 times before you get into your executive system even once. And we tend to give people, assumptions that they need anger management or something, but it's not, it doesn't work because anger management requires working a plan. And you can't work a plan without the executive system functioning. So we have to teach people, help people to learn how to experience parasympathetic dominance rather than sympathetic dominance. So we have to help them to get in a calmer state and stay in a calmer state, because when they're in that highly activated state, their memory is no longer reliable. They're subject to black and white thinking, binary thought processes, where you see whole categories of things the same, even when they're not. And you have limited self-reflection because that's not the part of the brain that they're working in. Lower self-awareness because they're focusing on the nuances and the dangers that are external to them, not what's going on inside. So they experience memory lapses, which looks like dementia, difficulty making decisions, decreased ability to concentrate, feeling distracted, and settling for what is. They give up. They give up on more. It is what it is. I'm good. Why bother? It doesn't matter. Those are cognitive symptoms of trauma. So trauma-informed care has to be that approach that aims to engage residents with histories of trauma differently, to recognize the presence of trauma symptoms, and to acknowledge the role that racialized trauma has played in their lives. The goal is responsiveness, integrating diversity-informed practices into trauma-informed care for nursing facilities is crucial for creating an inclusive and effective healthcare environment. Trauma-informed care recognizes the widespread impact of trauma, right, on individuals, and aims to create, a place, an environment that does promote safety and empowerment. But it's only when you combine that with a focus on diversity that you get to the nuances and the responsiveness to the unique needs of individuals from various otherized, racialized, and marginalized groups. because the trauma is so specific, but the trauma is also not often discussed. Don't talk about it. We don't talk about it. Maybe you can think of some practices that are widely accepted, or perhaps things that you've seen that might be traumatizing to someone from a more marginalized culture. If so, we're getting down to the end of our time. But if so, if you can think of something, please take a minute and type it in the chat. If there are practices that are, to be widely accepted, that might be traumatizing to someone. Someone
Turning
says
on the
turning on.
lights
Mm-hmm.
and
Mm-hmm.
waking
Okay.
residents up in the middle of the night to the toilet.
Yes. Yes, that's a great example. Yep, that can be traumatizing because if someone has experienced um, trauma that took place in the middle of the night, hmm, not going to go over well.
And I'm also
That's a great
seeing
example.
removing residents' clothes without telling them what they are doing,
Yes, another good example. Mm-hmm.
just walking in the room without knocking, leaving door open while doing care, bathing.
Mm-hmm. 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 Bathing, and sometimes you have to ask people, hey, is it okay if we? Well, not sometimes, really all the time. Is it okay if I? What are you doing? You're giving them control, and you're empowering. Hmm.
Thank you.
Touching a resident from behind, multiple people in the room during care. Yes, those can all be examples of situations where there can be trauma. I want to have time for questions. So what I'm going to do is just explain this case scenario to you and invite you to think about the fact that without an understanding of this man's history, he's going to be re-traumatized. Roberto was a 35-year-old Hispanic man. He's the son of parents who moved from Puerto Rico to the mainland US shortly before he was born, and they settled in Connecticut. His father wanted Roberto and his younger brother to assimilate into white American culture and had a rule of no Spanish speaking in their home. Long story short, Roberto tried to fit in with kids who identified as Hispanic. He wanted to identify with kids who identified as white, and he was bullied by social groups from both of those communities, even to the point at one time of being beaten and tied down, being threatened with an unsterile needle, and being told that that needle was infected with HIV. So Roberto fortunately managed to run away as they were about to stab him with that needle. Now Roberto's in a nursing facility recovering from surgery related to a very serious motorcycle injury. And he's terribly afraid of needles, but staff doesn't know why. So when it's time for injections or blood draws, the staff person actually tells him to be a big boy. It's only going to be a little prick. You can see the race, ethnic related trauma that causes this 35-year-old man now to be as afraid of a needle as a child might be. We have to begin to think about those kinds of scenarios because they're real. What you can do tomorrow: review policies and procedures to ensure that they're responsive to the racial, ethnic, and cultural needs of the residents that you serve. Incorporate trauma-informed care screening questionnaires in the intake process. Identified trauma experiences should be included in the resident's care plan, and coordinate with qualified professionals for trauma-informed care treatment services to support residents. Always thinking about the needs of this person's background, racially, ethnically, culturally. What trauma might this person have endured, traumatic events might this person have endured and experienced that's unique to their racialized and marginalized identity? technical assistance is available, and Nikki will talk more about that. But if we have a few minutes for questions and answers, I'm happy to take these last couple minutes and entertain your questions.